and supporting this work. And this webinar is going to be recorded and shared afterwards. So over the next 60 minutes, we will give you an overview of the work and the findings. We're going to hear from each of our panel members, and then we will have time for discussion and questions. So we're going to be using the Q&A function for questions from the audience, and please do enter your questions as you hear about the work and hear from our panelists. So I'll start with talking about the background of our work and some of the findings as well. So if we could go to the first slide, please. Excellent, thank you. So the independent review of the NHS by Lord Darzi was published in November 2024. And the review highlighted that the patient voice is not sufficiently heard, and this has contributed to the current challenges and the issues of the NHS. Alongside this, we've heard from government that one of the 3 ambitions is a shift from analogue to digital. So we should be expecting more services to become digitally enabled in the near future. And we are seeing lots of benefits from digitally enabled health services, things like remote consultations with specialists, the ability to receive care while at home, such as virtual wards or hospital at home, ordering medications through the NHS app using our phones, and receiving new digital treatments like VR therapies and app-based therapies. But these services are not used or usable by everyone. Our research that we published in 2023 found that there are fundamental barriers to digital inclusion. These fundamental barriers are devices, connectivity data, and the user skills and confidence. However, we also found that it's not only these 3 barriers that are important. Once people have overcome those barriers, people still find themselves digitally excluded because of how service and tools are designed and developed. Largely the reason for this is because people are not often engaged with how services are being developed and designed. So there's a lot of assumptions that are being brought into that process, or incorrect decisions that make services hard to use. So there's a real need to work with people and communities to develop inclusive and trusted digitally enabled services, but that doesn't happen routinely. So our work set out to explore what's needed to make working with people and communities routine and easier. To do this, we've drawn on published literature, we've conducted workshops to find what good practices are already happening in the health and care system, and we've also had a lived experience advisory group to help shape our thinking and work. So on the next slide, I'm going to briefly run through what we found. Firstly, it's about making engagement meaningful. And this means reaching out to a broad range of people beyond who you may usually talk to. And that can mean that we go out of the NHS sites, or we think about who we're talking to usually and who else we're not hearing from, and how do we engage with those people in a way that's meaningful. And that can mean making sure people feel heard. So examples might include communicating afterwards what was discussed and what's going to happen as a result of that, or perhaps using prototypes to support the engagement, to give people something to talk around and help to give examples of what things might look like, such as apps or service pathways. But it's really important that these kind of mechanisms don't become checking off predetermined decisions. So it's really important that they are flexible and you listen to people to make changes. It's also important to take inclusive and flexible methods combining in-person and digital methods, such as messaging or online meetings. And also, digital technologies can feel quite distant from people because of the language that can be used that can have a lot of technical expertise or jargon to it. So when communicating and working with people to make engagement approachable and meaningful, it's about using communication and language that is everyday language, so we don't create terminology barriers. Secondly, it's about the need to balance power dynamics. And by this, we mean that there can be different groups of people with different levels of experience and confidence and willingness to contribute. And that confidence and willingness can vary by who else is in the room, as well as where and how you engage. So engaging outside of NHS sites where people are most confident in a community setting can give more power to people that you're engaging with. Using neutral facilitators can help to keep all voices balanced, or alternatively consider engaging with different groups to keep people's voices as representative as possible. Thirdly, staff need support to be able to do the engagement. If staff are not prepared or supported, the engagement happens poorly or it doesn't happen at all. So it's really important to make sure staff have training in engagement methods and facilitation, and staff have to have the support of leaders to do this work and be aware that it is a priority. Fourthly, we heard about how time and funding are significant constraints, but also it's possible to make progress. And that takes partnerships with community organizations and charities to draw upon their knowledge and build upon what engagement has perhaps happened in the past, instead of repeating existing work. We've heard examples of maintaining community links and industry partnerships, which means you can access skills and access groups that NHS organizations may not have. It's also about taking a mindset of progress. So ideally, it'd be amazing to be able to engage with everyone. That's not always possible. So how do we engage with the people that is necessary to engage with to reduce inequalities, to improve access, to improve usability of particular services? So focusing on progress and moving forward rather than perfection can help to achieve good engagement in a constrained system. Lastly, we think it's really important that engagement is sustained. We find that when engagement is run on a project-by-project basis, a lot of that expertise and links are lost after a project ends, and a lot of that work needs to be repeated for the next project. So commissioning engagement and commissioning work should focus on making sure that there's a team that's always there and available. It should focus on not transactional metrics, but instead outcomes, and relying on the team and the expertise of the team to make sure that that engagement will meet the outcomes that are necessary. And then that also requires leaders to protect the funding and build the teams around having sustained engagement. These findings reflect what we heard from our workshops and what's already happening within the health and care system, so what's in the capacity of providers and leaders to do today. However, there's also an important role for leadership of providers and systems, as well as national leadership. So on the next slide, I'll just briefly talk through some of our recommendations for leadership and national leaders. We think that there's a need to invest in staff having the right skills, and leaders need to protect tech budgets. Often what we find is that tech budgets get raided, and the support around the technology can be eroded. And so there's a real need to protect tech budgets and allocate a portion of that. We heard that 10% works quite well, 10% towards engagement, so teams can continually be supported to engage with people who are going to be using those services, develop skills, and the links that are needed. Leadership needs to encourage and role model engagement in communities. We had really great examples of leaders going out of NHS sites to dedicating time to engaging with communities. These are leaders at department level, as well as chief execs of providers, proactively going out, role modeling how important it is to work with communities and hear from people in the community setting. There needs to be an expansion of who supports engagement. And this can be frontline staff and should be engagement with frontline staff, but also thinking broader than that to perhaps procurement staff, to ensure that engagement becomes a core expectation when tools and services are procured or commissioned. Finally, we see that there's huge potential for improvement in digital services through the richness of the data. That richness of data can give sophisticated insights for how people's behaviours and needs are changing, and what they expect, and how they are behaving around trying to access services. So we'd like to see trailblazer sites, those kind of sites that receive national funding, not just innovating on services and technology, but also on engagement and data insights. We see both in-person and data-informed approaches are needed, but we need to start with inclusivity and improve inclusivity today. So those services can be used more widely in the near future, and that subsequent data insight can help in the longer term to create more sophisticated services that work better for people. So hopefully that gives you a good overview of our work and some of our findings and our recommendations. Next, I'd like to introduce our panel. So we've got myself, obviously, Ahmed from the Health Foundation, who's a senior improvement analyst, Steph from NHS Thrive, who's an inclusive co-designer, John, who's been our lived experience on our lived experience group and a panellist member today, and Mary, who's all from NHS England and head of policy for healthcare inequalities improvement. So we're going to hear from each of our panelists in turn, and I'll start by asking Ahmed first to offer his thoughts, followed by John, Steph, and Mary. And if I could just remind the audience to submit questions, which we'll be getting to after hearing from our panelists. So Ahmed, I'd like to hear your thoughts, please.
Thanks, Pritesh, for the introduction. Hi, everyone. I'm Ahmed. I'm a Senior Improvement Analyst at the Health Foundation, and it's really great to be involved with this work and to see the sort of outcome from it. A lot of my research at the Foundation is on innovation, and within that, tech, data, and AI, with a particular focus on public and staff attitudes towards tech and data, which ties in really nicely with the work that Pritesh has just run through. And what we already found and aim to emphasize is that what people think really matters for innovation, especially if you want successful innovation that works for everyone, which is a core component of the work that Pritesh has talked through. We've seen with previous data controversies such as care data or general practice data of planning and research schemes that a lack of public support can significantly constrain innovation. And as such, there's a growing need to understand public attitudes on topics and engage with people. As Pritesh already mentioned, there's a lot of initiatives already underway, things like virtual wards, the NHS app, the federated data platform. So this context is really important now with the new developments and current developments already underway. And so to help build the understanding of what the public feel, we commissioned at the Health Foundation a nationally representative public survey to investigate attitudes towards health technology and data and the key factors affecting these views. And what the research and data provides us with is an understanding to what the population and the demographics within the wider population feel. But the King's Fund long read that Pritesh was talking through really provides practical examples on how we can resolve and reconcile a lot of those differences in attitudes in practice. So just to complement the work that Pritesh has run through, I'll be looking to provide a high-level summary of some of the results from the attitude survey that we conducted. On the whole, the overall public sentiment towards technology is positive. We found that 51% of people think that using technology makes the quality of healthcare better, compared to 8% who think it will make the quality of healthcare worse, and 29% who think it will not change the quality, with the rest saying don't know. But this kind of high-level results shouldn't be considered in isolation. While there are overall results that we sort of notice at that wider population, when we stratify the results across different demographics, we really begin to notice significant differences in opinion. For example, when we look at differences across socioeconomic backgrounds, we find that 65% of people in socioeconomic group A, so that's people who are from higher managerial, professional, or administrative backgrounds, they think using technology makes the quality of healthcare better. But that compares to only 41% in socioeconomic group E who agree, and that's people who are generally more dependent on the welfare state for their income. We also found within the results that there are varying levels of support for different types of technology, particularly around technologies that seem to come between or distance patients from staff in some way. That can be things like chatbots or robots that provide some personalized care. And in addition to that, as I mentioned earlier, considerations again vary significantly by demographics. So we found that across all demographics, the most important consideration for people was being able to see and talk to NHS staff when they want. But there are significant variations by age. For example, 4 in 10 of 65-year-olds and older said being able to talk to NHS staff was their most important consideration. And this compares to around 2 in 10 of 16 to 24-year-olds. We also wanted to understand how much the public trusts different organizations with their health data. And it probably doesn't come as a surprise that the NHS or NHS organizations were the most trusted among the public. And maybe not a surprise that government institutions were the least trusted. For example, 2/3 of the public trust the NHS hospitals and clinics with their health data compared to 1/3, so around half who trust local and national governments. So when we're thinking about co-design and engagement with the public, we need to think about how we leverage this trust and confidence in the NHS even more. And just to sort of link back to some of the recommendations and that Pritesh ran through, within the long read, there are some really other helpful recommendations that kind of facilitate this kind of way we can leverage the trust in the NHS even further. So we need to think about taking a flexible approach to engagement, with the results from the King's Fund long read suggesting that grouping people from specific demographics or specific levels of trust might yield better engagement. Meeting people where they are, so in environments that they're familiar with, can also help improve engagement. So while they do trust the NHS the most, maybe meeting them in a sort of neutral environment or environment they're more comfortable with rather than an NHS organisation. Building might be better, and having facilitation by intermediary organisational people, such as volunteers or community leaders, can also help balance power dynamics. And finally, our research shows that there are varying levels of support for the different types of activities people are willing to take part in when looking to shape technology use in healthcare, even if paid. And there are significant differences across different types of demographics, particularly socioeconomic groups. For example, we found that people in socioeconomic groups D and E were significantly less likely to want to take part in a workshop or attend an event, even if they were paid. So considerations beyond remuneration should be factored in. And we can infer from this that solutions are not necessarily representative that are being considered. So we need to think about solutions that break the cycle and work with communities to increase trust. And furthermore, another recommendation from the King's Fund Long Reach really supports this, is that we should think about how we engage with different groups separately to further avoid power dynamics or differences or balances in power. So just to conclude, the King's Fund paper that Pritesh has briefly ran through, it provides a lot of answers to some of the questions we were asking in our attitudes research. And if we do co-design better, as captured in the report, we can build better services that work for everyone, and by working together, hopefully has the ability to build trust in technology and data solutions that are implemented in the future. Cheers, Pritesh. I'm happy to pass on to the next panelist and pick up questions later.
Thank you, Ahmed. Really, I think that's fantastic work, and it really kind of exemplifies that we might talk about the public as one homogenous group, but that's not really true at all. And so some of the people that we talk to and we hear from might not be the people that have other views that we don't hear. So it's really important to kind of go out and talk to people. So thank you so much for that. Next I can see on screen is John. Hi, John. Would you like to share your thoughts on the work and what you'd like to see changed, please?
Sure. Thank you very much, Pritesh. So for me, the times when I have most urgently needed to access healthcare is when I'm approaching a point of crisis in my mental health. And actually, my ability to navigate digital technology is at its worst. I say this as someone who benefits from multiple forms of privilege, and I'm aware that those who suffer from intersectional discrimination may have whole layers of reasons why accessing digital healthcare may be challenging for them. As the report details, 8.5 million adults lack the most basic digital skills, and 2.4 million households struggle to afford their mobile contract. But on the flip side, last week my 8-year-old daughter asked if she could borrow my phone to use the note function to write down a recipe. "Why don't you use a pencil and paper?" I said. "Great idea," she replied. Clearly her interface with healthcare, as it is with making a chocolate cake, is heading in a very digital direction. The digitisation of healthcare is inevitable. What I would like to see change in the design of digital healthcare, I think, stems directly from working on this project, which has helped to crystallise some of my thought processes. The phrase that most resonated with me from the workshops that I attended was the call to meet people and communities where they are in the design of digital healthcare. This is physical location, but is also about meeting them in their communities, in their culture, and within their value systems. 100% Digital Leads provides a great example of this work in a community, in that they were consistently present in community centres, at coffee mornings, and through frontline third sector organisations. They made a conscious effort to tailor the digital offer to meet the specific needs of identified communities, and they also prioritised the groups and communities that were further away from equal opportunity of access. I think the language that we use to describe the design of digital healthcare is really important. One of the words that really stood out to me from the work and from the report was the word extractive as a mode of community engagement to be avoided. What I'm really interested in is bidirectional engagement. What is particularly pertinent for me is the context in which I choose to contribute my lived experience. For me, it's about using my experience of poor mental health as a means of empowerment, so that lived experience is an asset rather than associated with my own trauma. In this way, community engagement should empower health practitioners to design the digital health services that meet the needs of the communities and address health inequalities. And in that way, that community engagement is the source of power. I would like to see community engagement taking place across the course of designing digital healthcare, from the very start of problem definition right through to implementation and evaluation of solutions. I recognise resource constraints within the NHS, but being extractive is only going to exacerbate the health inequalities that digital healthcare, when appropriately co-produced, can address. The solution is in giving power to communities which have been systematically disenfranchised. Thank you.
Thank you, John. Really appreciate you sharing your thoughts and your experiences as well. I think you're very strongly put forward. Thoughts are great, and for me, there's a lot of things that I hear from people with lived experience around how services are hard to use when people are ill, and we should have services that are really easy to use because people are maybe not being able to think clearly and use services as they might be feel fully healthy. So really important thoughts there. Thank you so much. Next, we're going to go to Steph. Before we do, if I'd just like to remind the audience to submit questions, which we'll be getting to very soon. So Steph, as inclusion coordinator, it'd be great to hear your thoughts and insights, please.
Thanks, Pritesh. Hi everyone, I'm Stephanie. I'm an inclusive co-designer at Thrive by Design, and we're an umbrella organisation that sits under the NHS Trust, and we work nationally, looking at how we can try and develop, kind of iterate and implement inclusive, trusted digital services that meet kind of the needs of our diverse communities. So our work is centred on using inclusive co-design to transform health and care services. And we do believe that services have the power to improve lives, making healthcare much more accessible. But we also recognise that for many people, especially people from marginalised communities, that these services can present new barriers, in particularly around kind of trust, accessibility, digital literacy and cultural appropriateness. And all of these factors play a role in determining whether a digital solution is going to be truly inclusive. I want to talk to you a little bit about some work that we've recently undertaken with the Gypsy and Traveller community. We was commissioned to try and understand what some of the barriers and the challenges were for the Gypsy and Traveller community in accessing perinatal and maternal mental health services. The focus was to improve access and awareness of these services within the NHS. And we found that there was quite a few kind of challenges that people would kind of come across. A lot of these barriers were things that had been embedded, I guess, over time, more historical kind of challenges that people had felt from services, and not necessarily some of them was in relation to digital, but things that have happened over time, which kind of enable people to then have a fear of kind of judgment and discrimination. A lot of mothers felt that they couldn't be open about their mental health struggles due to the concerns that they would be judged, or in extreme cases kind of have children removed from them. And then there was also like a low awareness of available services, and then a limited trust in digital services. Some had challenges with digital kind of literacy or literacy in general, while others might have preferred kind of in-person settings. And in response to this, we identified kind of a number of enabling factors as well. So a lot of these enabling factors were building trust through community engagement. And in order for us to try and understand what these communities truly needed, we had to develop a really consistent, kind of familiar and culturally competent engagement kind of approach. And we did that with people, not alongside people, trying to understand what kind of things that people enjoyed, but for us to kind of go in and support with having those conversations. So a lot of our engagement was from a kind of creative, it had a creative element within that. And we did a lot of stuff in person. So I think we had a lot of stuff to be aware of when embarking on this project, because when you are engaging with a community like the Gypsy and Traveller community, a lot of the engagement takes place at people.
So it looks like we've lost Steph there.
People's home that we have, I guess, that comes from a place of privilege within.
Hi, Steph, can you hear us?
Hi guys, sorry,
You cut out a little bit there.
I do apologise. Sorry, I'll try and can you hear me okay now?
Yeah, I can hear you.
Yeah, I'll keep my
I think you
camera
cut
off.
out just before you were saying what makes it challenging to engage with traveller communities.
I'll quickly just go through some of the enabling factors. And we kind of heavily relied on using flexible and accessible communication as opposed to using written kind of materials or web-based tools. We wanted to really bring it back to that grounding on a person-centered approach. And we found that WhatsApp voice notes were a preferred method of communication, and it allowed for us to kind of be private, support people with kind of flexible access to health information, and people, it kind of broke down those barriers that people face from the community when engaging with health and care services. It was really important that we supported community champions. So these people might not have the title of a community champion, but people who are within the community, which are trusted people that people go to for support and advice. We worked with them, and we kind of encouraged advocacy through those people. And then our solutions were very much co-designed, and the community had come up with a lot of these solutions themselves. So a lot of lessons came from this work, and I'll just share a couple of them. But we must design with our communities, not for our communities, because we are providing services that people are using day in and day out, and these services need to be really appropriate to their needs. So we're trying to design solutions that people can reflect to and are reflective of their day-to-day lives. And we really want to embed cultural competence in service design, and digital solutions must offer a choice as well, because not everybody may be able to use a digital solution. So I do believe that digital solutions are fantastic and very enabling for some people, but is there a choice in the solutions that we're offering in the way that people can access those solutions? And then prioritising trust building whenever we're engaging with people. And I think we need to ensure that we're being transparent and accountable when we are trying to sustain and develop these relationships. And then we've also got the other one, which comes in with choice, I guess, but it's offering multiple engagement channels, because not everybody might want to use that digital service in the way that someone else is. So how are we able to kind of maintain that person-centered support? And whether it is a digital solution, can we use the use of voice notes and videos to communicate with people where possible? So I'll leave it there. I do apologise for my technology issues. Thank you.
Thanks, Steph, and really appreciate that reflection and sharing your experience. It's fantastic to hear of that work, and some really good understanding that's derived from going out and talking to traveller communities. Trust, I think, has been heard a couple of times in the last 10 minutes or so. So really, really driving home that message. Thank you. Lastly, we're going to hear from Mary before going to audience questions. I've seen a few questions coming in, so please continue to submit those. Mary, hi. Could you share your thoughts on wider determinants and digital inclusion and inequalities, please?
Yeah, of course. So hi, everyone. My name's Mary Hill. I'm Head of Policy for Healthcare Inequalities Improvement at NHS England. So I'm coming at this from a perspective of that wider inequalities agenda. And I think some of the reflections from across the panel so far are so insightful, particularly those themes that we're just talking about there, Pritesh, around trust, empowerment, building on community assets, really engaging people and going to where people are and building on those trusted community voices. I think going back to look at the pandemic, that's a lot of the learning from the pandemic as well, isn't it? Around how do we really engage with people in communities and go and meet people where they are and engage with community leaders and really have that authentic voice and work with those trusted community voices to really understand the needs of our communities. So a few different reflections. So you've asked me to kind of look at some of those social determinants and also linking this through to the 10-year plan. So I think it's important to reflect on some of the current policy levers as well around health inequalities more broadly, and how we can build this into the digital inclusion agenda as well. So in terms of wider context around inequalities, ICBs, one of the 4 key purposes of an ICB is around tackling inequalities in outcomes, experience and access. And I think it's really important that we are making the connection with the digital agenda and the shift to digital with these key priorities for ICBs. And some of those national levers, including the Health and Care Act, there are certain legal duties around inequalities. There's a number of requirements around data for both NHS England, but also ICBs and provider trusts as well around inequalities data. Is there an opportunity there to be really building in some of the expectations or requirements around digital in this space? And so we've got that systematic approach to how we're engaging with people and communities. So I think there are a number of opportunities there, and particularly as we look ahead to the 10-year plan, and also some of those key findings around inequalities from the Darcy review as well. So I think there's a few things there that are really important to reflect on. So from an inequalities perspective as well, through NHS England, we're very much focused on 5 key priorities. 2 of those are delivery focused around restoring services inclusively and accelerating preventative programmes, so that prevention agenda. But also digital is key, data is key, as is leadership. And I think, again, there's a number of interdependencies here with the findings of your research around some of the leadership space. And again, that co-production engagement with people and communities as well. So we published a couple of years ago now, back in 2023, a framework for NHS action on digital inclusion. And I think it's really interesting as well. There's a number of interdependencies with your findings from the King's Fund and the Health Foundation as well, particularly on this theme of trust. So within our digital inclusion framework, we've got a focus on access to devices and data, that accessibility and ease of using technology, the skills and capability for both staff and patients and carers in our communities, that focus on beliefs and trust, and again for staff and patients and carers as well, and that ongoing requirement. And then leadership and partnership as well. We recognise that digital inclusion is a whole of society issue. It affects us all in all aspects of our lives. And so digital is increasingly a determinant of health in how we access health services, and how we access employment, and how we navigate our lives, and increasingly important. And inequalities are intersectional. And I know a number of other panellists have spoken about the intersectional nature of inequalities. We know that, and I know there's been some other statistics shared, so just really reiterating some of those. We know that older people are impacted by digital exclusion, particularly people over the age of 75. We know people in more socioeconomically disadvantaged groups and those who are unemployed, again, experience inequalities and also digital exclusion. And particularly those socially excluded groups, we've heard about Gypsy, Roma, traveller communities, and also those people experiencing homelessness as well, disabled people and people with multiple long-term conditions, and people in rural areas, rural and coastal communities, again, experience inequalities, and access to digital services poses an opportunity, but also a challenge in terms of that connectivity and access to digital services. So there's a number of interdependencies. And I think one of the areas we haven't necessarily touched on yet as well, that we've been exploring in terms of that intersectional nature, is the intersection with health literacy as well. I think that's incredibly important. Some more statistics here to kind of share with you. 5 million adults cannot find relevant data in standard health information. 1.7 million adults are not able to explain symptoms and feelings over the phone. 1 in 6 adults have very low health literacy skills as well. So there's lots of challenges here. And I think another area that's also incredibly important is how we support people with little or no English. So National Voices data suggests that there are 1 million people in the UK unable to speak English well. And from our research, we've been exploring this and some real barriers there in terms of online forms, being able to access digital services in languages other than English. And I think some of the findings there around kind of WhatsApp and YouTube opportunities, how do we tailor to specific communities? How do we really engage with people from the outset? So I think community languages and that cultural competence approach, again, is incredibly important. So what does this mean in practice? How do we link this to some of those opportunities within the 10-year plan? I think absolutely, co-design, co-production, how we engage with people and communities is going to be incredibly important within the 10-year plan. One of the key work streams is around I feel included regardless of who I am. So I think that is an incredibly powerful opportunity, not only within the one work stream, but across the 10-year plan, that health inequalities perspective. How do we really hardwire inequalities more broadly into the 10-year plan, that systematic approach, and provide that leadership? I think there are a few opportunities. So, for example, how do we build in equality and health inequality impact assessments to delivery of services? How do you factor digital inclusion in some of those assessments? How do we make sure they're not tokenistic and actually have real leadership in this agenda? Is there that opportunity to have board objectives around addressing inequalities in leaders' kind of objectives across trusts, across ICBs as well? And how do we make sure there's that meaningful engagement with people and communities? I just want to flag that the CQC, in partnership with National Voices and the Point of Care Foundation, have recently published an engagement toolkit for integrated care systems around health inequalities. So how do we ensure that we can kind of, which has been co-designed with people with lived experience, so how do you kind of build all of those things into the 10-year plan? I think there are a number of opportunities there and policy levers to ensure it is really meaningful. But I'll stop there. There's so many areas we could explore.
Thank you, Mary, and really interesting to hear on how we kind of align the priorities and the goals of an organisation through boards to be able to do more of this work and bring it to the forefront. We also heard from you about the groups that are likely to be excluded. We've got a question about that, and I just wondered, Ahmed, if you'd like to expand on those groups that Mary mentioned from your work, and what particular groups do you think are more likely to be excluded?
Cheers, Pritesh, and cheers, Mary, for your thoughts. Really insightful on a lot of those perspectives. And in terms of the groups that are more likely to be excluded, from our research, we find that there's kind of key demographics where there are significant sort of differences. And the one that really comes up a lot is people from more socioeconomically deprived areas. And a large aspect of that is the kind of challenge in engagement. We asked, I touched on one of the results earlier, is what kind of would people be willing to engage in certain activities? And we found that people in those socioeconomic groups D and E would be less likely to take part, usually because the kind of incentive mechanisms can infringe on other things like their income that they receive from the welfare, etc. So there needs to be kind of solutions that aren't just blanket solutions for incentivizing, and the burden of responsibility being on policy, on developers, kind of decision makers, to find a way to engage with them. And there's also the age perspective, which I can see has come up in another question as well. And I think if we want to sort of improve that kind of engagement, I think the King's Fund paper really highlights just getting people involved from the early stages and removing a lot of those barriers that Pritesh and others have already highlighted. And just on the question on age, one thing that it's true that older people are generally seen to be sort of more averse to digital technologies. But one of the interesting things with new technologies like AI, we asked people in a separate survey whether they think AI will improve the quality of healthcare, and we actually found that younger people were more skeptical. So it's not necessarily just thinking about older people who sort of might be more skeptical, but even younger people now with new technologies that can also exacerbate further. So just thinking about getting people involved earlier and targeting and finding ways to incentivize the people in more deprived areas, I think, is a key component.
Thank you, Ahmed. What struck me from our work that we did in 23 was that there's a lot of ways of classifying people that they might be digitally excluded, but in reality, it could be just about anyone, and that status can change. So digital exclusion doesn't go from exclusion to inclusion, and then you're done. As we've seen with the cost of living crisis, people can no longer afford their internet connectivity or their devices, and once they break, they can't replace them, and suddenly they're digitally excluded, or they have an illness, which means that they can't use digital tools. And so it is about choice, as Steph mentioned as well. So I think there's partly it's making sure that there's choice, the technologies there that work for people, but also as a system, that there isn't the assumption that these people will be excluded and these people won't. We need to try and meet people where they are, which is asking what would work for them as part of that. Steph, it'd be great to hear if you've got any other suggestions on how we continue to meet people where they are, and some of your lessons and experiences around that.
Yeah, can you hear me okay at the moment?
I can, yes.
Yeah, brilliant. I think going back to trust and trying to build kind of existing relationships with people who might be using services is really key. But also engaging with them in ways that they want to engage with people. We might, I guess sometimes we might do research, or we might look at certain elements of research, and they might be done via a method, I guess, that people may not be able to kind of engage with that method. So we might see certain people excluded from those services, or from those survey results, because people wouldn't traditionally use that kind of method to kind of engage or communicate. So I think we need to get out there and be really creative in our approaches, and take the time to kind of build that trust. So whether that's in person, and whether you get 2 people that show up or whether you get 10, but building that into, I guess, funding as well, to ensure that it's something it's never going to remain static. It's something that's always going to move. So how are we able to kind of ensure that this is a continuum and it's not something that we're just going to do once and then come back to, but that feedback loop's really important with that.
Thank you, Steph. That's great. Maybe if I could, John, you want to come in?
Yeah, just really quickly on that trust. One of the things that came through in the workshop was one of the ways in which you build trust is by talking about failure, because the easy thing to do is to talk about when you've engaged the community, it's gone swimmingly well, and you're delivering great digital services. But it's not always that easy. So if you actually, it's part of that kind of cycle that Steph was talking about. If you go back to them and say when it was really hard and it didn't quite work, people identify with that better as humans, and you're able to work more collaboratively to problem solve.
Yeah, it's a really good point. That reminds me of something else in the workshop about being open and honest about what's on the table. So some services might already be tied into 10-year contracts with particular tool sets, for example. So what is changeable might not be everything, but being open and honest with people when you go out for engagement, that this is a service that you've heard could be improved. These are the constraints of things that are unchangeable, but we'd like to see what we could do is a good way of trying to move things forward. I'd like to come back to you as well, John. We've got a question around what the panel considers to be the valid points around digital inclusion, exclusion, how that's different from standard services. For me, there's something about language and how digital can be culturally seen as being quite different. It's got a lot of technical jargon to it, which can make it quite different in approachability compared to physical services that we all grew up with. And then there's also something about data and how data is being used and the trust around the data. That means that sometimes you need to approach co-production around digital services differently from physical services. But John, it'd be great to hear any reflections from yourself as well.
Thank you. It was a really good question as well. I mean, I think the question was kind of looking at the exclusion criteria for kind of digital healthcare. And one of the things there is digital literacy. So kind of my read of how it's different is a lot of what we're saying is generalizable, but because of issues with digital literacy, the experience of of not being inclusive is kind of exacerbated. And actually, I think Mary talked about this really effectively, in that digital literacy is strongly related to other social determinants of health, whether that's employment or education. So the kind of effect becomes, I don't know, not quite exponential, but heading in that direction. And then kind of my other reflection, and I think you kind of articulated this as well, Pritesh, is there are ways in which for some people, digital healthcare is the exact opposite of meeting people where they are, which means that you've really got to try harder in the design to get it right, because the risk is that the end point is quite alienating. So I think there's a kind of greater sense of urgency and need there, is my reading of it.
Thank you, John. We've got a question about the importance of engaging with communities. I'd like to turn to you, Mary, on this one. Many third sector organisations are trying to do this with no funding at all, and that makes it hugely challenging. So how is the system and providers, how can we start to align better to prioritise this kind of work and get commissioning or engagement to be working alongside third sector organisations?
Absolutely. I think it's an incredibly important point. I mean, the voluntary sector isn't free. We need to be supporting the voluntary sector to be around the table with us and as part of that engagement as well. I think we've got a number of reflections from some of the health inequalities additional funding from the last few years, and how we have worked with colleagues across the system to really make that case for investment and doing things differently in how you're engaging with people and communities. So for example, we've been encouraging our ICBs to invest in the Core 20 Plus Connectors programme. So again, about engaging with people and communities and working in partnership with the voluntary sector. I think what's really quite important is bringing along our finance colleagues on board with the agenda, so that they kind of have that understanding of the benefits of engagement and of collaboration. Our communities often have some of the most powerful answers, and they're not necessarily the most expensive answers either. Some of the solutions are already with our communities in meeting them where we are. And I think Pritesh, you mentioned procurement leads as well. I think there's the opportunity through procurement, through social value around inequalities more broadly, but there's also around, actually, for me, part of my role as well is making that investment case with finance colleagues. So working with finance colleagues so that they understand the benefits of investing in engaging with people and communities, in addressing inequalities and the practical things that they can be doing through their work, through demonstrating return on investment, I think is important as well. So we're bringing people from different disciplines together to really understand the importance of meaningful engagement. I come back to the kind of the CQC engagement tool, and I think that's really, really important, because it is about bringing leaders on board with that journey as well, and how we're engaging with the voluntary sector and investing as well. So
Thank you.
I think it's quite challenging, but I think it's about bringing people on the journey with us.
Excellent. Thank you, Mary. So very much around working cohesively as a team and across different professions within that organisation as well. Yeah. Steph, if I could come to you next, it'd be great to hear a little bit more about the work that you've been doing. We've got a question around the governance around digital inclusion, and it can sometimes be owned by no teams. So it's not owned by the digital team or the inequalities team, and there can be a lot of conversation, but without that ownership, but the engagement doesn't necessarily happen. So it'd be great to kind of hear how you and in your work and navigate those kind of complexities.
Yeah. It's a really good question, and I'm not always best placed to answer this. I'll answer it as best as I can, and it's something that comes up kind of time and time again for us. We do try and keep our engagement as flexible as possible within, obviously, the constraints of working within the NHS. we have the usual, I guess, tools and things that we do around kind of consent forms. But we are really clear, I guess, when we are engaging with people that we kind of set the, we set the tone at the beginning of every kind of engagement piece of work that we kind of embark on. And the ways in which we do that is working with people to kind of create some shared kind of values and kind of boundaries around the work. So we make it really clear that people that we remain open and we remain transparent, and that we don't want to be extractive from people as well. I think trauma-informed, looking at kind of trauma-informed kind of methodology is really helpful when working with communities and trying to ensure that what we're doing and the conversations that we're having is not going to leave people any kind of worse off. So it might be that we have people in the room who are supported, who can support people, I guess, to navigate challenging conversations, and that we can take pauses at any point. But really, we tend to work with the organisations that we work with, and I guess the people that we work with, and we're guided by them. So usually some of the questions that we ask at first is kind of, what is your process through having conversations with people? Like, how do you kind of document and record these things? And we try and kind of follow, to some degree, as much as we can within the NHS, the same kind of lead. We have somebody who is part of our team who is a little bit more kind of up on like the GDPR processes, who we can go to if we do get stuck. But to be honest, it's usually something that we're able to kind of navigate. Something did come up around kind of WhatsApp, and we was using WhatsApp messaging and voice notes, but what we did do is worked with Leadsgate, who then kind of sent out our voice notes for us. So Leadsgate is a community organisation who support Gypsy and traveller communities, and they worked with us as partners on the project. So we would develop kind of the voice notes and the voice note messaging, and then Leadsgate would then be the ones who kind of communicated that to the community for us. So we didn't at times have that direct kind of contact with people, and actually it worked really well because they had trusted people who worked at Leadsgate, who knew the community, who supported the community quite regularly. So yeah.
Thank you, Steph. We've got a question around the use of prototypes. So I just kind of answer that question. In our workshop, we heard from how important it is to work with different partners, and one of the skills and the capability that can give access to is the ability to develop quick prototypes or access past prototypes, to be able to bring those into an engagement session. And it's really helpful to kind of help people to give an idea of what a service or an app or a tool might look like, and help to kind of then shape ideas around that. But as I mentioned, it is really important that it isn't set in stone or ticking off what's already been decided. And so being able to be flexible in that room with the prototype helps to kind of give people transparency about how changes may look, and what the ramifications of another 10 choices on a menu might look like when you're trying to navigate through a tool. So we're quickly getting to the end of this webinar, and I'd like to invite our panelists to give their closing reflections. So I'll come to Ahmed first, and before I do, just to make sure you're aware, Ahmed, there is a comment in the questions around AI and young people. So if there's anything you'd like to add around that, please feel free to do so.
Cheers, Pritesh. I think just on the whole and moving forward, I think what the work you've done and sort of some of the research we've looked at in the past, it just sort of emphasizes the importance of not having a blanket approach for solutions, and so for future actions or policy recommendations to be very sort of targeted and specific to address the kind of differences in nuance, in attitudes towards different technologies, data, etc. And I think moving forward, if that's the case, then I think further sort of solutions and implementation of digital tech will be more inclusive. So I think that's kind of a key priority or key takeaway from me. And I think sort of just relaying that to the AI point from the chat, I think, yeah, it's really important just to make sure that things are quality assured and checked across all demographics to make sure they do work for everyone. Otherwise, inequalities will just be continued to be exacerbated.
Thank you, Ahmed. John, if I could come to you next, and then Steph, and then finishing with Mary.
Sure, thank you very much. I mean, for me, it comes back to having a patient voice consistently at the heart of these conversations. And I think it was actually Steph who kind of mentioned it. Sometimes doing that is going to be confronting and it's going to be challenging, because if people feel systematically disenfranchised and you have a real conversation, they're going to articulate that. But my feeling is that those times of confrontation and those times of challenge is actually when you can make the most progress, and that's really important. Even if sometimes it isn't easy, you're much likely to get to a better situation.
Thank you, John. Steph.
I think services and kind of, well, digital services in particular, being reflective of people's needs and continuing to be reflective of people's needs is something that I'll kind of take away from this, and the importance, I guess, of building in feedback loops, not just at the beginning of something being developed or kind of deployed, but continually kind of being iterated on to ensure that we're taking relevant feedback from people, and that's then reflective in kind of the services that we're offering.
Thank you, Steph. Mary.
So I think from my perspective, it's thinking about the opportunities that the 10-year plan offers to really hardwire engaging with people and communities into that longer term. And also that kind of systematic approach to ensuring that inequalities, health inequalities, are considered through developments of new technologies that will evolve over the coming years and at pace, and ensuring that, as Ahmed has mentioned, kind of not exacerbating inequalities, not creating new inequalities, and really hardwiring that in for the longer term. And also, how do we then support both staff, people and communities with the skills and capabilities to make the most of those opportunities where it's right for them, but also ensuring that non-digital offers are still available for people where it's not necessarily appropriate to be in the digital space.
Great, thank you so much. I think in closing, what I'd like to add is, I think it's really important that we recognize design isn't just making something look nice. As Steve Jobs quote, basically, I'm going to paraphrase so badly, but basically, design isn't how it looks, it's how it works. And so good design and good digital services should work well. And that might be introducing new things, or it might be stopping combining services in ways that work better for communities around making them more accessible, making them usable, making them improve people's outcomes, better experience, etc., etc. It's not just making something look good. And there's different ways of doing that, and hopefully you've heard that today, and you can look at our long read as well as watch back on this webinar in future. I'd like to thank our panelists, as well as the Health Foundation and the people who have engaged in our workshops and our interviews. And we hope to see you again soon. Thank you.